Hello, welcome and kumusta, and thank you for joining me. This is How. I am your occupational therapist, and welcome to OT Conversations. This podcast is intended to students and to those clinicians who wanted to refresh themselves with some of the foundation information regarding occupational therapy, or sometimes you probably just want to get entertained about some random information involving occupational therapy, or some relevant information involving occupational therapy, or perhaps we want to celebrate people, in which case it'll be rollicking individuals involving occupational therapy. Whatever the conversation, it's going to be a riot, and it's going to be a wonderful conversation. In this episode, I'd like to talk about the myotomes. Here, I'd like to dive into the topic that is crucial for us to understand spinal cord injuries, particularly the muscles that are affected at various injury levels. So if you're in the profession, or if you're a healthcare professional, occupational therapist, probably member of the public who wants to be entertained as well, or to understand, or simply someone who's just interested in the subject, this episode is for you. When we talk about spinal cord injuries, it is important for us to understand that there are different levels of injury. And I'll give you a quick breakdown of this. So in cervical, around the neck, there are 7 vertebrae. So it's from C1 to C7. In the thoracic region, you can have 12. In the lumbar region, you have from L1 to L5, so you have 5. And then the sacral region, you would have from S1 to S. And each level would correspond to specific muscles and their functions, which is what we will be exploring in this episode. Now let's talk about the myotomes and their muscles. So it's really going to be very straightforward. So C4 level, when somebody has a spinal cord injury and C4 has been spared. So just remember, C4 is the one responsible for diaphragm. So when somebody has an injury at the C4 level, the diaphragm is affected, and this can impact on breathing, on which case some of the patients will be using some form of ventilatory support, or they might use some form of ventilatory support, or they could be relying on some accessory muscles when they are breathing. So it's particularly at a very high level of injury. So going down, if C5 is spared, just remember with C5, the ones that are intact would be the biceps muscle and the brachialis muscle. So at the C5 level, the biceps and the brachialis muscles, they are involved, and they're primarily responsible for elbow flexion, both of them. It is also important for you to note that C5 will contribute to both elbow flexion and supination, particularly the action of your biceps muscle. When it comes to brachialis, that is purely elbow flexion, but with the biceps being involved, then there will be some form of supination as well. It's actually quite a strong supinator. Now on the C6 level, the ones that will be spared would be the muscles called extensor, carpi, radialis, longus, and brevis. And these are extensors of the wrist. If you want to understand it, it sounds like a big word, but it just by the name alone, extensor, carpi, radialis. So extensor, that's English, definitely. Carpi would be a carpal bone, extend the carpal bone. Radialis, which would have been a reference to the origin. So extensor carpi radialis. And then longus would mean that it is a muscle that is long, and brevis would be a muscle that is wide. So understanding their Latin root words can actually help you visualize the muscles much better. C7 is triceps brachii. For those with C7 injury, the triceps brachii muscles, they are the ones that are spared, and these muscles would facilitate the elbow extension. These muscle group they have 3 heads, hence the name triceps. Yeah. So biceps, if you go back to it, biceps, you have 2 heads of the muscles. So when C8 is paired, you have a flexor digitorum profundus. This is crucial to finger flexion, especially when you are flexing the very end, the distal phalanx. So profundus, flexor digitorum profundus. T1 would be the action of the abductor digiti minimi, which is responsible for the abduction of the little finger. And this is actually quite specific, isn't it, when you're talking about the extensor digiti minimi? But it has to do with abductors of the fingers. That's it, really. The muscles beyond T1, so from T2 to T12, the focus here is more on the trunk muscles, and they're actually providing more stability rather than actual movement. So you cannot isolate movements if you have a T2 spinal cord injury or T12, but you can tell that T10 would be the dermatomes for the umbilicus, and T4 would be the dermatome for the nipple. So these are some of the sensory, but then we are talking about movements here. So in reference to the head, we are just talking about C4 all the way down to T1. After that, then we go to the legs. You have L2. It starts with iliopsoas, and the L2 will affect the iliopsoas muscle, and this is more essential and especially useful for hip flexion. That's the prime mover. Iliopsoas, that flexes the hip. L3 would be quadriceps, and the quadriceps will contribute to the extension of the knee, and there is an influence on the hip flexion as well, but it is a weaker hip flexion, but there is more action on the knee extensor. Quadriceps, meaning there are 4 of them. Okay, so you have the rectus femoris, you have the vastus medialis, vastus lateralis, and then the vastus intermedius. Quadriceps. L4 will be the action of tibialis anterior, and this will help an ankle to do a dorsiflexion, and it is important when you're walking, and it prevents foot drop during movements, and particularly when you're walking and it does the heel strike. The reason why you're able to do the heel strike is because you're actively doing the dorsiflexion whenever you are walking. So if you have L4 and that's spared, then you should expect a dorsiflexion movement. L5 would be the movement of the extensor hallucis longus, and that's it really. So dorsiflexion or extension of the big toe. So that would be S. When it comes to S, you would have the movement of the gastrocnemius and soleus muscles, and this is the calf muscles. And these are responsible for plantar flexion of the foot. And with S2, there will be some movement on the anal sphincter. But it's very seldom that you'll have to assess that unless you're doing it for academic purposes. But for practical reasons, sometimes it's very difficult to do that, because you wouldn't just put the person on side lying and then just get them to actually contract their sphincter, won't you? So that's not practical to do. So that's it really. I wish I could make it even more simple and even more exciting. But these key myotomes would correspond to movements, so the levels would correspond to muscles. And it is very important to know this, because this is a foundational knowledge in occupational therapy. And it is very important when you have to understand your intervention with spinal cord injury cases. So guys, I hope you learned a little something today. Just remember, anything you do matters and has an outcome. Until next time, bye. If you enjoyed this podcast, talk to your friends and colleagues about it. Like it, subscribe, share, and do what you can to appease whatever algorithm that is at play. Just remember, guys, anything you do matters and has an outcome. Until next time, bye!